sir, respected MD sir, respected seniors, and my colleagues. Today we would discuss glimpses of superficial fungal infections. This is the season for it. During the moist, warm and humid climate, there is exodus of these fungal infections. And superficial means the very superficial and the superficial ones. Those one who stay above the skin and those who infect the upper layers of skin like epidermis or to be more specific, the superficial most layer of epidermis, the stratum cornea. So these are basically of three types. One is dermatophytosis, the commonly called that ringworm, jock itch, etc. Then cutaneous candidiasis, that intertrichotype, and the pityriasis versicolor. Dermatophytosis are those which have a affinity to the stratum cornea. They require keratin for their growth, so they stay on the places where there is keratin, on the skin, on the hair, on the nails, but they do not invade inside. So these are different from the subcutaneous mycosis or the deep fungal infections, and these are never able to cause any systemic fungal infection. There are basically three types. One is that microsporum, another is epidermophyton, and another is trichophyton. The trichophyton rubrum, trichophyton tonsurans, microsporum canis, these are the different names. And commonly these are called Tinea infections or ringworm. These can be, mostly these are anthrophilic, spread one person to another through fomites, etc., through the doormats, through the towels, commonly used towels, etc. And one are the geophilic, that especially the non-dermatophytic mold or dermatophytic mold, some like aspergillosis, fusarium, these are spread from the soil. These are different from that subcutaneous or deep fungal infections like sporotrichosis or histoplasmosis or coccidomycosis. These remain on the surface of the skin. These do not invade the epidermis to go to the subcutis. Or zoophilic, like that these come from the pets. Now, when this dermatophyte invade scalp, we call it Tinea capitis. When it is on the body, we call it Tinea corporis. When it invades hands, palm, we call it Tinea manum. When it invades feet, we call Tinea pedis. When it is in the interrural areas, we call Tinea cruris, like this. So, Tinea capitis is infection of the hair follicle and the surrounding skin. It is a predominantly we come across this in the children aged 8, 9, 10, 11, 12, like this, pre-adolescent children. This is basically of four types. One is that diffuse scaly type, which mimics seborrheic dermatitis. There are dandruff-like scales. There is the hairs are broken from almost their root, but the hairs are there, and these can be felt or seen. These we call grey patch. Another is that black dot type, that the hair follicle remains there. In fact, the hair follicles are overactive. These project from the scalp hair like black dots, and the area of alopecia, these are started with stub of that broken hair and the hyperactive follicles. These we do not usually come across. This is mostly seen in the black population. And commonly we come across two forms. One is the commonest form is that seborrheic dermatitis type, that diffuse scaly grey patch type. But after that we come across that Carian and Favas type. Carian is one boggy swelling, fluctuant boggy swelling, which closely mimics cellulitis, scalp cellulitis. It is painful. It is the only fungal infection that is painful. The fungal infections are usually not painful. These are itchy or asymptomatic, but this is the only fungal infection which is painful, and there is associated cervical lymph node swelling, lymph node lymphadenopathy. So there is doubt of whether this is bacterial folliculitis turning into cellulitis, or this is a Tinea capitis presentation. And there is another type which is called Favas. Favas is it is like what we see in neonates, like cradle cap. the scale is thickened. There is scutula like it is like basically the cow dung cakes. White cow dung cakes are studded on the scalp around the follicle, and some of these the adjacent these wallets to make a big patch. This can be elevated also. This is scutula, and the presentation is called Tapas. These are the basically broad classification of Tinea capitis, and actually the hair gets infected. From that, the surrounding skin also gets infected, and then the infection goes deep in the follicle. So these are some of the presentations. The middle one is the diffuse gray patch type. That right one is the you see there is a boggy swelling. It is the carrion type, and left one is the also seborrheic dermatitis type. There are flakes like dandruff. So differential diagnosis when scaling and inflammation are predominant, it may be confused with seborrheic dermatitis or atopic dermatitis or scalp psoriasis. But isolated scalp psoriasis is common. There should be associated changes in the elbow, knee, nail, etc. And when alopecia is predominant, then it is confused with alopecia areata. But alopecia areata is there is no hair point is same. It is absolutely shiny. And traction alopecia is on this area, temporal area, due to the tightly bound hair backwards. And trichotillomania, the length of hair in trichotillomania varies because, and that is on the on such area which is easily pluckable. Now, this is one of the commonest presentations in our clinical practice, that is onychomycosis or Tinea unguium, the nail infection of the fungi. Nail may be infected with dermatophytes, nail may be infected with the candida also. Mostly it is dermatophytes. It is more in the toenail because feet remains more moist than the hands, and it is more seen in the immunocompromised people, diabetics, and it is often associated with psoriasis, with nail psoriasis. And like HIV infection also, onychomycosis has become more common. It is of 4 types. One we most commonly see is the distal subungual type, that it is on the most distal part along with the lateral border. It is called distal and lateral subungual onychomycosis, and the proximal one is called proximal subungual onychomycosis. One variety is the superficial one. The nail gets broken, and there are broken marks or roughness seen on the superficial nails. It is seen both in toenails and fingernails. It is easiest to treat amongst the onychomycosis. This is basically superficial onychomycosis, and that the area looks white, so it is called white superficial onychomycosis. And another is that total dystrophic nail, total dystrophic onychomycosis. The whole nail gets dystrophic. It is very difficult to treat. At times, all 20 nails are infected. In case of HIV or diabetics, it becomes very difficult to treat. There, we should try to enhance the nail with chemicals like urea 40% and give systemic antifungal. Onychomycosis has to be treated with systemic antifungal. No, almost other than that, superficial white onychomycosis, no role of any topical therapy. And candidial nail infection may occur, but it is not so common. The pictures, that right one is that starts from the superficial distal area, distal subungual onychomycosis, and the left one is the whole nail involvement. The right area absolutely up to the distal part it is involved, and the lines are seen transversely going, which are called fuse line. It may be black also, considering the above, depending on the infecting fungi, the color may be black also, black, brown like this. Tinea corporis, when it involves body, we most often come across, we call it ringworm because it is shape is like a ring, annular, but there is a scale on the active area. The typical book description is active margin with central clearing. So the center remains clear. And as the infection progresses, it starts as a small papule or nodule, then gradually it progresses like the advancing edge of a ring, and the center becomes clear. Other than few varieties which are called Tinea imbricata, where there is concentric rings, or some granular form of Tinea where there are in the center also there are some granular-like projections. Mostly it is very easy to diagnose with the active border, active red elevated papular border with central clearing with itchy presentation. And pruritus and burning are the common presentations. The differential diagnosis is actually hardly there is any differential diagnosis. Actually problem becomes when a fungal Tinea corporis gets treated with topical steroid, then it becomes Tinea incognito, it becomes difficult to treat, it becomes incognito. Then it gets confused with erythema annulare centrifugum or nummular eczema. But granuloma annulare is basically a deep papule. It is not seen on the, it is intradermal papule, it is not seen on the skin surface. There are some pictures like it may be adjacent, it may be solitary. Behind the pinna there is, you see the active red border is very much appreciable. There is Tinea cruris we call job heat, is more predisposed due to wearing the underwears and during this humid climate. You see the scrotum and genitalia usually remains spared. It is very rare to come across Tinea cruris on the scrotal or penile skin.
Cause? Kyun?
I don't know. But in clinical practice, we have seen. And that differential diagnosis is that intertrigo may be candidal. Candidal intertrigo is very common. And there is not such central clearing visible. It may be erythrasma. Erythrasma mostly we see on the axillary area, and there may be mechanical intertrigo due to the tight underwear, borders of underwear. The inverse psoriasis is a very close diagnosis, and inverse psoriasis is definitely it is a challenge. If with 3 or 4 weeks of antifungal treatment it does not give desired result, then psoriasis, inverse psoriasis should be thought of. Psoriasis usually occurs on the extensor, but inverse psoriasis involves the flexors, and though it is rare, it is not unseen. And seborrheic dermatitis, we call scrotal dermatitis, it is also very common. Tinea faciei, it gives pleasure to diagnose Tinea faciei because presentation is very subtle. That elevated border is not so elevated, and it is also, especially in kids, it is easy to diagnose. In elderly male, it is very difficult to diagnose. And it becomes very diffuse. It is not, when it is apparent on the extremities or trunk, it is very easy to diagnose. But Tinea faciei is difficult to diagnose, but some patient has come to you with maybe months of treatment with something else, and you have given something oral, and after 2 weeks or 3 weeks of oral therapy, it gets disappeared, it gives pleasure. Tinea faciei is a pleasure to diagnose and treat. And it may be contact dermatitis also. It may be polymorphic light eruption if it is on the area near